Before the advent of cane, people were treated by plate and screws for the femur, which are not that effective, and they were also treated by a prolonged period of traction, which in most cases resulted in malunion and in some cases in non-union. And therefore, this is one of the instruments that revolutionized orthopedics. Let us see what are the things that you have to look for in a cane. First, the cane is slotted. There is a slot at one side. It is not a complete circle. Second, a cane has got two eyes or eyelets on either side. On this side there is one eyelet, and on the other side also you have another eyelet. Now, it is this eyelet which is used for extraction of the canine, and this eyelet should be protruding out through the trochanter in all cases. Let us see how the canine is inserted. Now, the canine is inserted in such a way that the slotted surface should point anterolaterally, because the curve of the femur is anterolateral and the canine should come in this manner. Then, how is the canine inserted? The canine is inserted in a retrograde manner. That is, if this is one fractured bone and this is the other fractured bone, you don't introduce the canine through this side and then through this side like this. No. Classically, it is said that Kunshar did the anterograde nailing in both, or in almost all his cases. But the classical method of cane nailing is a method of retrograde cane. The cane nail, as you know, is used for fractures of the femur. Now, this is a bone model of the femur. And just imagine that there is a fracture here. The best place for inserting a canine is actually not this area. The best place is this, and this place is called the isthmus, meaning the narrow zone. Now, why is the isthmus of the femur the best place for putting a canine? Now, the canine depends upon a 3-point contact. The first point at the end, the second point at the other end, and the third point at the fracture site. Now, the first point and the second point is not of much consequence, but the point at the fracture site should have a snug fit at the fracture site. If it is a wide area, then there will be movement of the canine inside, which makes it unstable. So, if it is an isthmus fracture, it is as if the bone is tightly holding the canine both at the distal end and at the proximal end, and there is no movement between the canine and the fractures, which means there is no movement between the distal and proximal ends of the bone. So, to insert the canine, you go through a lateral approach. An incision on the lateral side, you cut the fascia lata, you see the vastus lateralis muscle, and it is lifted off the lateral intermuscular septum, and you immediately see the femur. Once the femur is visualized, the canine is inserted, like we said, through here, and it comes out through the trochanter. At this point, the patient's leg is kept flexed, and the canine finally comes out through the trochanter, like so. At the other end, the canine is finally driven till it is flush with the bone, and the other bone is taken using another bone holding forceps and kept in contact. The reduction is not by simply pulling it like this. Just remember that anterior and posterior to the femur, you have the strongest muscles in the body, and no man, even an orthopedician, can simply pull the bones like this and bring it here. The bones are reduced by a technique called toggling. It is flexed like this so that the tissues on this side are relaxed. It is made to come into contact, and then it is reduced by hinging the bone onto each other and finally reduced. Now, with the legs kept in the same position, this part which is kept outside is rammed back into the femur and until it crosses the fracture site, and ideally with a small part of the nail sticking out so that you can remove it later. And this finally finishes the operation and you have a fixed fracture of the femur with the K-nail inside holding it. The K-nail is now replaced by a newer instrument called the interlocking nail. Now you remember that even though the clover leaf shape of the K-nail allows from some amount of rotational stability inside the fracture and holds the bones without rotational stability, this is not complete. Therefore, what you need is something that provides complete rotational stability, and that is the interlocking nail. The interlocking nail was first invented by Modney, and it has got some specific advantages. First thing, it gives total rotational stability and it is a stable internal fixation, unlike the K-nail, which can allow for some amount of sliding. You can see that the interlocking nail has got two holes on the top and two holes on the bottom. It is these two holes which allow for fixation of the screw through the nail like so. Once the nail is fixed with the screw through the proximal holes and the distal holes, this allows for something called rotational stability and does not allow the nail to rotate inside the bone. And this is specific for interlocking nail. The second indication is for a comminuted fracture which tends to collapse, and the interlocking nail with two screws on either end will allow the fracture to stay in place without collapsing. But the most important thing about the interlocking nail is none of these. The interlocking nail is inserted in an antegrade manner through the trochanteric side and without disturbing any of the tissues at the fracture site. This is called biological fixation. You do not disturb the fracture hematoma, which has got so many of the factors which allow for good fracture healing. So, this is an instrument which allows for biological fixation in contrast to the K-nail, which needs evacuation of the fracture hematoma for the fixation. This is the way that a interlocking nail is inserted in the patient without opening the fracture site. The interlocking nail finally crosses the fracture site. Now, I have already made a hole in this distal area through which you can see the things which are behind me. Just keep looking at this hole and you will see that the nail has now come and crossed the hole. At a certain point, the whole of the nail comes into view of this hole. Once this is done, you pass the screw through this hole and fix the nail. And this is the final fixation. This screw is going through the bone and also through the nail. So you can see that this interlocking nail is now strongly attached to this segment of the bone. A similar fixation is done on the top, and you can see how good the fixation is. It allows for no movement up and down and no movement to the sides. This is the magic of the interlocking nail, and this is the one which is the preferred method of fixation for all the lower limb fractures nowadays. The problem with the interlocking nail is you don't have a bone with a hole which is ready to accept your screw. All this has to be done under CM. The amount of radiation which is gotten by the surgeon may sometimes be tremendous for a person who is doing a large number of interlocking nails. So proper precautions have to be taken. The locking is done after passing the nail, viewing it through the C-arm, making the hole and then passing the screw. There is no ready-made hole inside the bone like I have demonstrated here, because this is just for a demonstration purpose. So once again, this is the interlocking nail, which allows both for rotational and for longitudinal stability. Once we are finished with the large nails, let us now go on to the smaller ones. Of these, you have got the nails for the radius and the ulna. This is the radial nail and this is the ulnar nail. The posterior end looks alike for both, with threads actually for purpose of inserting and also for removal, but the distal ends are very much dissimilar. You can see that the ulnar nail is simply tapered at the end and it is quite symmetrical, whereas the radial nail has got a peculiar shape. Now, why does the radial nail have a flat surface on one side and a peculiar notch and a bevel on the other side? The answer to this lies to how these nails are inserted. When there is a fracture of the forearm bones, the radial nail is inserted in an antegrade manner and the ulnar nail in a retrograde manner. Classically, both of them have to be inserted in an anterograde manner, but the ulnar nail is usually inserted retrograde for a convenience purpose. So, suppose you have got a fracture of the ulna and the fracture site is here. You pass the nail with the back side facing to that fracture site and through the ulna until it comes out through the olecranon. Once it is in this position, the fracture is reduced here, and just like the K nail, this is advanced until the fracture is stable and this end is flush with the olecranon and not sticking out of the skin. The radial nail, however, is inserted in a totally different manner. Why? Because the radius has got a different anatomy to that of the ulna. The ulna has got a joint at this end, but it is free at the other end. The radius, however, has got a joint at both ends. Here you have the radial head and here you have the wrist. If you try to introduce it from the fracture to this side, you will go through the wrist, and to this side you will go through the elbow joint. Therefore, the radial nail has to be inserted through a notch either in the listus tubercle, and some people prefer the radial styloid. In your own hand, just palpate below the thumb on the radius and you will find the radial styloid. From the radial styloid, you palpate to the ulnar side and you will find a bony prominence around here, and that is the listus tubercle. An incision is made here, and that is done with after the incision there is a small hole which is made using the awl. With the awl, a small hole is made in the cortex of the radius, and then the radial nail is inserted in this manner. Because the radial nail is inserted at an angle to the radius, there is a chance that it will hit the radius and come out through the opposite side. This is not desirable. Therefore, the radial nail should hit the other cortex like so and bend and then continue anteriorly. For this, there is this bevel, and to facilitate the bending of the radial nail, there is this notch. So, the radial nail goes into the radius, hits the cortex inside the bone, and then straights itself and goes forward. Once it goes forward, it goes to the fracture site, crosses the fracture site, and finally stabilizes the radius. So these are the radial nail and the ulnar nail, of which this modification is called Thalwalker's modification, this notch, which allows for bending of the nail. The radial nail can be, or ulnar nail, can be mistaken by a novice by the K wire.